Okay, good evening, everyone, and welcome to Urology Part 2. My name is Dr. Mohammed, one of the F2s in KSS.
And my name's Hannah. I'm also an F2 in KSS.
So the plan for today, obviously after going through a lot of theory yesterday, is to look at a few cases and see some practical applications to the theory that we learned yesterday. And we want to make this as interactive as possible, so please use the chat function. I'll be asking questions, and so will Hannah, very regularly. So just make sure to make use of that, and just take advantage of this interactive session so that you come away with the most benefit. So I'll just share my screen. Okay, so we're just going to jump straight into it, just like last time. So our first case is Mr. Smith, lovely Mr. Smith there. He is a 64-year-old gentleman, and he's presented to hospital today because he has found some blood in his urine. So hematuria for the first time. He's never seen this before, and he's read online that this is a very concerning sign and, could be a sign of cancer. So he's concerned. So he presented to the hospital looking for some advice and hoping to have that sorted out. His past medical history includes hypertension, osteoarthritis, and atrial fibrillation. And he is on apixaban, bisoprolol, and amlodipine for his regular medications. So, what might you want to do next? And Hannah, if you just keep an eye on the chat for me, what might you want to do next in terms of asking further details in history, or examination, or investigations? Can anyone think of what would be appropriate to do now?
The chat won't be public, by the way, so I'll just see what's coming through. So just, message anything. Don't feel like any answer is stupid.
Okay, so have we got anything, or should we proceed?
Yeah, I think let's carry on.
Fine. So, of course, that's just a very brief history. So you want to take a bit more of a detailed history and ask a few more questions to ascertain potential causes. As we said last time, hematuria can be caused by several things. It could indeed be a tumor that's now bleeding. It could be renal stones. It could be...
Oh, we've had a message into the chat. So someone has said, ask if there's any pain. Very good point. Is this the first time they've had hematuria? Are they feverish?
Fantastic.
Someone else has said, take a deeper history. When did it start? How long has it been going on for? Frequency, I think that's in reference either to LUTs or how often is it happening, if it's a recurrent thing, and past medical history.
Fantastic. So I agree with all of those things that were mentioned. Yeah, you basically want to take a more detailed history and dig around and try and figure out what this hematuria was really caused by. One thing to always remember, guys, for those of you that are medical students and are about to do your OSCEs in a few months, or even for the F1s and F2s out there, any question that you ask a patient, you want to make sure that there's a reason why you're asking them that question. If the question that you ask them doesn't cause you to go one way or another in terms of ruling out or in certain diagnoses or changing your management plan in any way, then there's no point asking that question. And you're wasting precious time, whether it be in terms of your time as a doctor or your time as an actor doctor in your OSCE. And of course, that's important. And asking the right questions just shows that you, instead of just going through a blank Socrates or anything like that, just shows that you're in control of the station and you know what you're doing. So of course, you want to take a detailed history. and ascertain potential causes. Like we said, pain is definitely a suitable one because there could be different causes of that hematuria. So renal stones can sometimes cause blood in the urine if it's caused a certain amount of irritation to the ureteric linings. And so that's entirely appropriate. It could have been caused by trauma. It could have been caused by a new malignancy in the urinary tract. It could be caused by an infection. That's why asking about a fever or urinary frequency is entirely appropriate. So well done, everyone, for that. Another thing that we mentioned last time, of course, is the patient on any blood thinners? In this case, we know that he is because he's an AF patient, so he's on apixaban, and that's something obviously very, very important to be aware of and note down. When doing further investigations, you of course want to do some bloods, and particularly FBCs and U's and E's, and that's because one of the things that you want to look at is the patient's hemoglobin. And that kind of ties into the question in the chat where someone asked, how long has this been going on for? Is it the first time? Because if it's been going on for some time, then maybe this is an indicator that the patient has been bleeding for quite a long time. And thus, maybe their hemoglobin is quite low and they need admission just on that basis alone. So again, you want to make sure that your history and your investigations complement each other. So bloods, what's the patient's hemoglobin? Something to note, actually, I think I mentioned it yesterday's session, and this is once again really important in your OSCEs in particular. Always compare whatever result you're given to the patient's baseline. Okay, so someone with a hemoglobin of 90, but the baseline is normally 92 or 95, that's not concerning at all. But someone with a hemoglobin of, let's say, 95, so even higher, but their baseline is 140, that is concerning. And likewise for your symptoms and whatnot. Now, how are you going to manage this patient? Well, you want to catheterize them to have a look at if they're not passing urine readily, then you want to catheterize them anyway and monitor the urine that is being drained from the catheter. What color is it? Are there any clots? How bad is the hematuria? If the patient's urine is rosé in color, so remember we described that as, for those that maybe aren't familiar with that, if they people don't drink or whatever, then diluted squash. Think of diluted squash. If it's that color, then there's no need to keep them in, especially if the hemoglobin is stable, they're not in any pain, and they're not in retention. Then they can go home with, of course, a TWAT clinic referral to remove that catheter in 2 weeks' time. And of course, given that this patient is not in pain, he doesn't have a fever, there's no active infection, the hemoglobin is stable, the hematuria isn't that bad, and it's not been going on for too long, then we point towards the likely cause of it, which is probably just a DOAC. Okay, so he's been bleeding as a result of side effect from his DOAC. So of course we want to hold that, and typically we hold that for around 3 days, or just as long as whenever the hematuria settles, whatever comes first, basically. And of course, remember that although in this patient it may be straightforward, it's just simple AF, but other patients, they can have a complicated history, and it can be the reason why they're on the DOAC in the first place can be quite complicated. So if that is the case, then you want to discuss with the appropriate team, so either hematology or cardiology if they're on it for some kind of cardiac event. So just and this happens quite frequently, actually. So there was one patient that we had on the ward not too long, a few weeks back, who had significant hematuria. His hemoglobin, believe it or not, was actually as low as 24 on presentation. I don't know how he was walking around. Yet, and obviously he was on, we wanted to stop that bleeding for obvious reasons. We gave him a lot of blood to bring his hemoglobin back to safe levels, and we wanted to stop any further bleeding. Yet we incidentally found that he had a new DVT in his right leg. So again, you come across certain situations where it's a difficult balance, And at that point, you really should be making the decision after a discussion with the appropriate teams. So if you find yourself in that situation, then of course, seek help. And of course, remember, he's presented with new hematuria. And, I think, as mentioned in the chat, rightfully so, you should be suspecting cancer or something that you want to rule out. So remember, he doesn't need to have those investigations there and then, but definitely a 2-week wait referral needs to be put in for cystoscopy and a CT urogram. And this is absolutely essential that you do this because, this could be the one and only presentation that he has with, this potential new cancer. If you aren't the one to put this 2-week wait referral in, it might never be put in. And the next time he presents to hospital could be, once his cancer spread and become metastatic. So it's really, really important that you don't forget to do that. And likewise, even for OSCEs, it's a good thing to mention. Okay.
I'm just going to interject. Someone else has put something into the chat about a question you'd asked in the history. Is the hematuria throughout the urine stream or only at the start or end of the stream? I think in my experience, and this is similar with rectal bleeding, patients don't really distinguish. They see blood and they get quite stressed. With the urine, typically a drop of blood will kind of discolor the whole urine. So it'll only be obvious if it's kind of at the start of the stream without any urine coming, which I guess could happen in like a prostatic bleed, or in the case of trauma, that could maybe happen. I don't know if you've got other thoughts.
No, completely agree. I think it's important to. I think you realize this more when you start working. Sometimes the niches that you find in theoretical medicine aren't necessarily present in actual life. And unlike Hannah said, the patient, as soon as they see a drop of blood in their urine, they're alarmed, and most times they don't, because they're not thinking like a medic. They won't pay attention to these minor details. Anyways, so he goes home. You've put in the 2-week wait referral. He's happy. He's got his catheter in. No issues there. But a few days later, 5 days later, Mr. Smith is back. And he's not as happy as he looks in this photo because his hematuria has worsened. It's become, more prominent. It's no longer rosé. It's a lot darker. And he's also noticed that his catheter is no longer draining. He noticed that this morning, and it's left him in some discomfort. He's got a bit of abdominal discomfort there. So what do we think might be going on? What's caused this discomfort that Mr. Smith is in? And again, we're going to keep an eye out on the chat. So I'll give you a minute. Any ideas?
Nothing on the chat so far. Oh, we got two, and they both say, "Is there a clot in the catheter, or a stone?"
Fair enough. Okay, fantastic. So whoever said clot in the catheter, well done. That's the right answer. So his hematuria has gone worse. What's happened is that the blood that's in the bladder is now congealed. It's formed a clot, and that clot has blocked up his catheter. That's why it's no longer draining, and it's also left him in retention, and that's why there's some discomfort there. Now, which investigation should be undertaken to confirm whether or not he's in retention? Simple question. what thing might we do?
Someone has said a bladder ultrasound. So
yeah, fantastic.
Bladder scan.
A bladder ultrasound, in other words, a bladder scan. Remember, I guess in this case it doesn't really apply, but yeah, a post-void bladder scan. And it shows that he has 650 mils in his bladder. That definitely shouldn't be there, especially if someone is catheterized. So he is indeed in retention, and specifically clot retention. So what are we going to do? We are going to manage that. And we do that with bladder washout and irrigation. But first of all, we need to, if this current catheter is blocked and we've been unable to unblock it, then first of all, we need to put in the right catheter. So if you guys remember from yesterday's lecture, the suitable catheter to use here is a 3-way catheter. And let's remind ourselves, it's got 3 ports. The first port in which the balloon here is inflated to just secure the catheter in the bladder. And then it has an inlet which allows for any flushes of water to go in, and an outlet to allow the urine to drain. So how does a bladder washout actually occur? So I'm going to try and explain it just from this photo. So you've got a 3-way catheter in, and what you're doing, the idea of a bladder washout is to break up the clot that's caused the retention. So essentially, you've got the urethra coming out of the bladder, and a clot is sitting on top of the urethra, and it's causing a block, hence not allowing the urine to pass freely into the urethra. So as such, you need to break that clot apart. Remember, a blood clot is not like a stone. It's not a hard, calcified material. It's just a bit of blood that's kind of clotted up. So with water that's pushed in at high pressure, it can be broken apart. And when it's broken apart, it's broken apart into smaller pieces and fragments. And those fragments should be small enough to pass through the urethra and drain out. So what you do is you fill up a 60 ml syringe with water, and then push it into the bladder using the inlet in the 3-way catheter at a high pressure, and that should allow the clot to break apart. You do that several times just to make sure that any clots are appropriately broken apart. And what you can do as well is then connect the syringe to the outlet to then draw up and help with the process of removing any clots as well. So that's step number 1, and that's to break up the clot, okay? But ultimately, if the patient is actively bleeding, then they will inevitably fall back into clot retention, because if there's blood coming from the bladder or elsewhere in the urinary tract, that blood would congeal, it will clot up, and eventually it will cause clot retention again. So to prevent that, you need to make sure that the bladder is continually being irrigated, i.e. water is being passed through, once again, as you can see in the image here, into the inlet, and it's being passed through to the bladder and essentially irrigating the bladder continuously, and that would be continuously draining out of the outlet. That means that any bleeding that is taking place in the bladder will not have the chance or enough time, basically, to clot and then cause that same problem. And this is what the difference between bladder washout and irrigation, so you guys are aware. Of course, remember, and I want to highlight this specifically because I guess it may cause confusion in some people. When someone has a clot in the bladder, you need to hold the anticoagulation and not give it. I know you may think that in other parts of the body, whenever we have a clot anywhere else, whether it be in the leg, if it's a DVT or a PE or anywhere else, we give anticoagulation to break that clot apart or to aid in that process at least. But that is not the case in clots that form in the bladder. And that's because those clots are formed as a result of bleeding, not just pure thrombosis. So instead of giving anticoagulation, we hold anticoagulation. It may seem obvious to some, but I know it would be causing confusion in others. So you want to stop any bleeding in the bladder. Okay, if there's any questions, do pop them in the chat, but we'll move on to the next case. Okay, case number 2, we've got Mr. Jones here. Mr. Jones is a 55-year-old man, and he has presented to hospital because he's had difficulty passing urine in the past 24 hours. He's again got growing abdominal discomfort, and he also reports recent weight loss, but he's unable to quantify that weight loss. His past medical history is not very significant. It includes an appendicectomy back when he was a teenager and an end STEMI that he had in 2019. A post-void bladder scan shows that he's got 1 liter in his bladder. So, which further investigations might we want to do for Mr. Jones? So we know he's in retention. What further investigations might you want to do? Is there anything coming through in the chat? What do we think is going on here with Mr. Jones? He's in urinary retention, but what could be causing that urinary retention?
Someone has said digital rectal exam, bloods, PSA.
Fantastic. Very good. So, to be fair, the history, there's definitely a lot more questions you could ask Mr. Jones to get more information from the history. But yeah, he's having difficulty passing urine. The growing abdominal discomfort is due to the retention, and he's got recent weight loss. And we know in men of that age group, they're at risk of prostate cancer. But first, we want to investigate the retention a bit more. So you might wish to do a CT KUB, you might wish to do an ultrasound KUB. Anyway, on his one, you find bilateral hydronephrosis. Bloods, his urinase show a creatinine of 286 with a baseline of 80. So he's got an AKI, and that's very significant in terms of whether or not we choose to admit this patient. Of course, like you said, you would want to do FBCs, CRP, in this case, definitely a PSA as well. And you do a digital rectal examination, of course, and that shows you that this patient has a craggly prostate. Okay, so now our suspicions, unfortunately, of prostate cancer are increasing. What do we want to do? Well, we might wish to do further scans to look for, as you would with a patient in which you're suspecting prostate cancer. So CT cap, an MRI prostate, a bone scan. Of course, not all of these scans need to happen on the same day, but in some patients we've had an audit, it can happen. So, but yes, of course. And if those the PSA comes back very elevated, and you find what you were dreading on these scans, then you need to inform the urology cancer nurse specialist. And that's because he or she will be the expert in terms of managing these patients, breaking the bad news to them, walking them through the various steps that will come after this diagnosis, and of course, an MDT referral so that this patient's case can be discussed. Now, that's all well and fine. So hopefully that's all sorted. We've informed the cancer nurse specialist. She's gone to break the bad news and, just counsel the patient through all of that. But back to the immediate issue. Our patient is in high pressure urinary retention, okay? And we know that because of the large volume that he was retaining, the bilateral hydronephrosis, and the AKI that he's in. So which catheter would we use here? Remember back to yesterday's catheter slides. So should we use a convene catheter? Should we use a suprapubic catheter, a three-way catheter, a two-way catheter, a team and tip catheter? What would we use and why? And A&E are asking for help because they can't catheterize the patient. They're struggling. They've tried several times and they've been unsuccessful. So they want urology's help.
Someone has said the curved tip one.
Fantastic. So... Okay, excellent. So yeah, you might wish to use a team and tip catheter. And that's because, to be honest, first you probably attempt with the normal two-way catheter because that's really what the patient needs. But if you struggled or it's not possible, again, and this is very likely because of his enlarged prostate and of course his restricted or constricted rather prostatic urethra, then you might wish to use a team and tip catheter, which makes things a bit easier going past the prostatic urethra. So yeah, well done. That is probably the one that you'd use, and hopefully that would be successful. Fine, but we're not done there yet. We've catheterized the patient. Is that it? Let's say, so we've catheterized the patient, it's draining. Are we done there? Can Mr. Jones go home with, follow-up under urology and oncology? Or what should we do here?
Someone has said we need to manage the AKI.
Fantastic, yeah. Okay. So managing the AKI we know is caused by the hydronephrosis, and we know the hydronephrosis is caused by the retention. So hopefully once you've catheterized the patient, there'll be a gradual resolution of the hydronephrosis and a gradual resolution of the AKI as well. So it should happen, fairly quick. So maybe over the course of the evening or the next day or two, things should be resolved unless there's another cause of the AKI. But yes, very good. In terms of the catheterization itself, of course, I just included this one here because I forget to do this as well, to be honest, is make sure to document the catheterization and put the, the sticker at the back of the catheter packet in the patient's notes. A lot of the time, you may forget and then you're forced to go back and get it from the bin, which you don't want to be in that situation. So just remember to do that first of all. Also, when catheterizing the patient, you want to make sure to avoid serious complications that might occur like paraphimosis. So to avoid that, make sure you return the foreskin back to its original position. Remember, Hannah discussed this yesterday. A lot of the time, paraphimosis is simply caused by, catheterization. But in the process of catheterizing, the healthcare professional does not return the foreskin back to its original position, and then it can cause some very serious, complications. So avoid that. And also, we want to monitor, of course, for post-obstructive diuresis. So we covered this yesterday as well. He's had a large volume of urine retained in his bladder. It's caused hydronephrosis to the point where he's developed a good-going AKI. So his body is now at risk of developing post-obstructive diuresis, where he's just flushing out all that water and all of those electrolytes. And so we need to monitor his urine output very closely for the next few hours, and for the evening, basically, and also his electrolytes. Remember, we defined post-obstructive diuresis as someone producing a urine output of 200 mils or more per hour for 2 hours or more. So you want to make sure that that's not the case. If it is the case, then like we said, monitor the electrolytes very closely and correct any imbalances. So that's really, really important. Sometimes, again, you just generally you find patients who are in retention, they've got a distended abdomen, you catheterize them, and you feel like you're an amazing doctor. You've solved the problem. But remember these things, because you don't want to have accidentally caused harm to the patient without realizing, or just left them without further monitoring. Okay, well done, guys. Excellent. On to case 3.
Okay, so I will take over for case 3. As usual, keep messages going into the chat and questions, and we'll answer them as we go along. I've got an eye on the chat, so I'll see them come up. So we've got Mrs. Williams, a 60-year-old female who has come to A&E with severe left-sided flank pain. It started yesterday, comes and goes. She's vomited twice today, but denies having any fevers. Her past medical history, so she's got gastroesophageal reflux, she's got diabetes, and has had a ureteric stone in the past. So take a moment to kind of picture the patient in front of you. That's all the information you've got so far from a quick history. What else do you want to know? Either in terms of, what you'd be looking for when you're casting an eye on the patient, and any more questions from the history. It's a very broad question, so just fire anything into the chat. So someone's asked, is there a history of LUTs? Yep, that's a good thing to ask about.
Okay.
All right. So from what I'm thinking, when someone gives me that history, and with that past medical history, there are a couple of things that you want to sort of dig into a little bit more. Obviously, the pain, it sounds quite colicky. It sounds like a renal stone. Obviously, this is a urology teaching session, so it is a stone. But that she's had a previous stone, and something that you might want to dig into more is what happened with that stone. Was that just she had an episode of colic? Yeah, exactly. So someone's just said, how was the stone managed? That's quite an important thing. Was the stone treated? Are they waiting for treatment for a known stone? How did they present last time? Were they, severely infected and obstructed? Have they had a stent before? All of those kinds of things. And then in terms of thinking about risk factors for what could make someone very unwell, diabetes, is this type 1 diabetes, is it type 2 diabetes? Are they on any medications for it, which someone has also mentioned in the chat? And then obviously your kind of end of the betagram, are they well or are they unwell? Are they currently doubled over in pain, or are they actually quite comfortable? These are all the types of things that will very quickly guide your thinking of, are they going to need admission, or could you potentially send them home with some pain relief? But obviously you're going to get a CT-KUB. And in this case, it shows that Mrs. Williams does have a 5mm distal ureteric stone. So distal meaning rather than being sat up in the renal pelvis, it's a little bit closer to the vesica ureteric junction. and you're going to do some bloods. Now, well, okay, I won't ask this question. So why are we doing bloods? Obviously, get an idea of is this stone causing an infection? UNEs, because we want to know if the stone is causing an obstruction to the point where the kidney is being affected, so causing a post-renal AKI, and their CRP, obviously again for infection markers, because actually even if someone is presenting clinically like fairly okay, but they've got quite a stonking CRP, then I would, as Mohammed mentioned yesterday, people can become very sick very quickly. But particularly the like relatively fitter population, they might initially present okay, and then they'll actually fall off a cliff. So it's maybe better to just keep them in for 24 hours and monitor them. The urine dip is negative, so that would indicate that, or it kind of put us down a slightly, put her in a sort of lower risk category, because you know that there's less likely kind of an infection around there. There's no blood in the urine, so we're kind of, let's say, a new score is 0 as well. So we're along the safer end of things. Now I'll put the question to the room: Would you tee this person up for surgery, or would you manage it conservatively? What have we not delved into quite so much that would be an indication for admission for this patient when she's not infected, not very badly obstructed? So I think yesterday we went through sort of 3 reasons why you might consider admitting someone and managing a stone surgically. Yeah, so it could be the size. I think that's probably more. 5 millimeters isn't like a massive. Obviously, a bigger stone is more likely to cause a degree of obstruction that would cause a drop in renal function, etc. Yeah, so someone's mentioned analgesia and watchful waiting. So what I hadn't really gone into was how much pain she was in, and are the medications she's taking at home managing her pain, or has she been needing IV morphine from the door in A&E? Because if someone is in so much pain from a stone that they're not going to be able to get out of it, then they need to be admitted, and we would consider stenting someone just because of pain. So exactly in this case, we might admit her, give her good analgesia, still prepare her for surgery, because if the pain doesn't get better, i.e. if she's not starting to pass the stone, it's a distal stone, so maybe she could pass it with a bit of tamsulosin. Someone said drink lots of fluids, but we'd probably just go for IV fluids in this case, especially if we're teeing her up for surgery, and then just see how things are the next day. In terms of what analgesia we would give, so PR diclofenac works really well. This patient, she's had a stone before, so she's probably familiar with PR diclofenac and may well even have some at home. And that's always quite a good indicator for whether you're going to admit someone or not, because they might have already tried PR diclofenac and it hasn't worked. So obviously, if you're an A&E F1, it's not you to make the decision anyway, but it is up to you to make that kind of assessment of, are they in so much pain that they'll need to be admitted? And what's another important thing to consider? Obviously, we've put her in the low risk category for infection, etc. But what should we be doing? Essentially, we want to be making sure that we're keeping regular obs in case she does become infected, because she's got diabetes. We don't know exactly how much that could be impacting her immunity. So always prepare for the worst. And yeah, if they become septic, then definitely inform the on-call reg, because that's a reason for them to be stented overnight. Yeah, exactly. So someone's just put in the chat, monitor for sepsis risks. And again, thinking back to the diabetes, if they've got really poorly controlled diabetes, then they would maybe need to be put on if they have type 1, then typically they would be put on a variable rate insulin infusion anyway. If they're type 2, very poorly controlled, then they might need to be put on a variable rate. So there are always lots of things to think about with these things. Okay.
Oops.
Does anyone have any questions about that in terms of the indications for admission, etc.? It's the kind of thing that you get used to on a urology job. It's not something you need to know the ins and outs of that thoroughly if you're in other jobs, but it's definitely, if you're on A&E, you'll get a sense of it. The important thing is just doing the basics of assessing, are they sick or not, what do they need immediately, and referring to urology essentially, or just asking for advice. Okay, shall we move on? So we now have a 17-year-old who has reported a kind of new sudden left testicular pain, started this morning, felt a bit embarrassed. This is the first time it's ever happened. He says he's recently become sexually active. So, that's quite a sparse history. What else would you guys want to ask about? Let's say, firstly, from a pain perspective, what would you want to know about his pain? So what I would ask about is a kind of, because obviously, as from our session yesterday, in the back of your mind, you always want to have torsion, as in you want to be considering torsion. So someone said dig more into the characteristics of the pain. Is it unilateral? Is it bilateral? Whenever someone's presenting complaint as pain, I think a good question to ask is, what were you doing when the pain came on? Because if someone is able to describe the exact thing that they were doing, that would typically suggest to me that it was a sudden onset. Whereas if they say, it was at some point in the morning between 8 and 10, that's actually more of a slow onset than a kind of like bang on. We've got lots more things in the chat. Very good. Exactly, severity. So, is it constant? Is it intermittent? That's a very good point, particularly with distinguishing torsion. So all very good thoughts. And some other things I would add in is, has he got any urinary symptoms, so LUTs, or other symptoms of an STI, like kind of pus coming from the uterine meatus or something? Is he systemically well? And obviously past medical history, etc. So we examine him. The left testis is tender. It looks a bit swollen. Not sure about the chromosteric reflex, because quite often we won't be, but Prensign is positive. So if you remember from yesterday, Pren sign is where elevation of the testicle relieves pain. So what's our working diagnosis? Well, we've got it up there. It's epididymoorchitis. So this is quite a classic history. We think it's probably been driven by an STI that he's acquired. But obviously we still want to be ruling out testicular torsion. From this history, it's, I think we can pretty reasonably say that it's not torsion. But if you're ever unsure at all, then, A, ask a senior, or B, just ask urology to come and have a look at least. What kind of investigations would we do? So yeah, full blood count, UNEs, CRP, all of that usual stuff. And that probably would have been done for you already if you're in A&E. Urine dip and culture, that's really important, and an STI screen, because this is driven by an infection and you want to know what infection to treat. Ultrasound testis. So why would we do that? Anyone from yesterday or any newcomers want to put that in the chat? So there are a couple of reasons we could do an ultrasound testis. So A, it will provide us with more reassurance that this isn't a torsion. B, if we think there might be an abscess or a kind of like a complex reactive hydrocele or something, then that will show up on an ultrasound. And if we think there might be a testicular cancer underlying, then that would also be reason to get an ultrasound. Yeah, I think. So continuing on with the management, provided we've ruled out a torsion, reassurance. Obviously, this can be quite an anxiety-inducing thing, especially when it's the first time. And you want to be managing the underlying cause of epididymoorchitis, so antibiotics, analgesia, typically, simple analgesia will work, and a scrotal support. And then further management, obviously explaining to them that this is an inflammatory a kind of reaction to an infection, and the way they can prevent it happening again is by preventing infection. And as we've already said, repeat an ultrasound testis in 4 to 6 weeks to look for a potential mast tumor, because with all the inflammation going on, you might not immediately see it. Kind of similar to repeating a chest X-ray in 6 weeks' time when someone has focal consolidation when they're presenting with a pneumonia. And I think that's case 4 done. So thank you again for everyone's participation. Lots of very good points in the chat, and hopefully you got some use out of it. These are, I don't know if the people contributing are medical students or doctors, but I think the salient thing is, a lot of this stuff you'll get used to it from experience. But all the stuff that you've said so far has been bang on. So keep up the good work.
Yeah. I think either way, if you are medical students, then you're definitely set for your OSCEs, and if you're doctors, then you're very good doctors. So well done, guys. Excellent stuff. Again, we'll stick around for maybe a couple minutes if there are any questions.
And we've put the feedback QR code up there, so please please scan that.
Yeah, Hannah, I don't know if you had anything to add or
to
any final remarks.
Final words? No.
We've got a question. So case 3, obstructing stone. If surgery is appropriate, what procedure would be used? So typically, what I've seen on the wards is a URS, so a ureteroscopy, which is basically similar to cystoscopy, a camera that goes in, but goes all the way up to the ureter, just to first of all visualize the stone. And once visualized, then they'll use laser beams to fragment the stone and allow it to come out that way. That's typically what happens. If they face any difficulties, for example, the ureter sometimes is too tight, or for whatever reason they can't go ahead with that, then the surgeon will choose to put a stent in, and that basically allows the ureter to be wide enough to allow the stone either to pass on its own or save it for another day where he can attempt again to break it apart. So that's typically why.
And crucially, the stent, it relieves the obstruction as well. So typically, because ureteroscopy, it won't be available overnight. So if someone is presenting as an emergency, then they would just have a stent put in. I can't remember if we actually explained what a stent was yesterday, but it's essentially just a little tube that goes into the ureter past the stone, and that allows urine to drain. And as Mohammed said, it would also potentially help with the stone passing. People, just a note on stent is that some patients have really awful experiences with stents, so I wouldn't kind of launch into. That's why it's good to know if someone has been stented before, because they might be very averse to having another one. And I've kind of scared some patients before talking about stents when they would be absolutely adamant to not have one. So yeah, that's kind of an emergency. The key thing is relieve the obstruction, drain pus if there is any, and then the gold standard is ureteroscopy with a laser. But depending on where you are, the waiting list can be quite long. So some people go home with a stent for quite a long time.
Good question, though.
Yeah.
And Emily, you're welcome. Good luck with your exams. Yeah. Guys, we can actually see who has scanned the feedback form, and it says just one person. So if you're watching and you've still not scanned it, then please scan it. We can see you. We'll leave it there for another minute. Okay. You're welcome, guys. So fine. I think that's probably it. You're welcome. You're welcome. So yeah, we'll leave it at that. I think questions are probably done. Hope you enjoyed and benefited, and yeah, good luck with exams, everyone. And thank you for that person that just scanned the QR code. We can see you. Anyway, we'll leave it there, guys. Thank you so much. All the best.
Bye.